I am a palliative care physician, and I want to talk about what true palliative care is and how we kind of shift the mentality to achieve this, not just in healthcare, but in our daily lives, so that we can live and love and learn and grow through every breath we take. This conversation tonight is not about dying, not about death. I can't change that. You can't change that. That is an inevitable line in the sand, one which I honor and I respect. But the real conversation is, what is sacred to you as a human being as you approach that line, given whatever you're dealing with, from a medical perspective or otherwise. And so this is really tailored around that point specifically. When we change the conversation, when we empower people to understand what they're dealing with, good, bad, or indifferent, and align what's sacred to them with true opportunities of care, we have outcomes that change the absolute playfield. So in my last position, over several years, I cared for several thousand people, the sickest of the sick, from diagnosis. But not just the last few days, weeks, or months of life. We're talking 86, 90, 98 plus months out. 94% of the people I cared for never had to go to the hospital. Not because I stood in front of the emergency room, waving them away, but when we engaged with them and shared with them the reality that we're talking about tonight, and we said, help us understand who you are as a human being. What are your values? How do you want to live your life? And we aligned care mechanisms with that. We precluded a lot of fear. We knew what was going to happen. And so we stood side by side and walked with people, and they wanted to be at home. And they wanted to pee in their own toilet and sit in the lazy boy and watch Jeopardy and have their grandkids bounce on them. And that's okay. Let's do that. We reduced the number of people who were cycling through the system for symptom issues, social, economic issues, behavioral health issues. Again, we listened and we heard, and we aligned what was possible. We had availability 24 hours a day. Every patient I've ever cared for had my cell phone number. And while I didn't go to the bathroom for 2 years because we were so busy, there was value in providing that care because it was a shared human experience. And so this last one, 70% per capita reduction in expenditure. We provided more care congruent with what people truly wanted in real time. They lived longer, and their quality of life was better, with the highest patient satisfaction scores out of the entire Unity Point Health system. And in addition, we had the most likelihood to refer to others coming from patients and families. But these conversations are not about dying, they're about living, and they empower hope. So true palliative care, we are in our pre-adolescence as a subspecialty. And we had formal accreditation a decade ago. So we're accredited by the Board of Medicine as a specialty. And there's been a lot of palliative care shingles hung out in front of healthcare institutions and organizations without really understanding what it is, can, and should be. A lot of bias and ignorance came to the field at its inception from other specialties. I don't think it's out of malice, but rather ignorance and lack of experience. And so what it traditionally has been is come in and have the conversation so that someone can make a decision about if you want to die in a hospital or die at home. I ascribe that true palliative medicine is about this conversation and philosophical platform we've been talking about tonight, and it expands the spectrum of current health beliefs, and it's a current model for population health, and that When I sat on the board, we looked at how do we care for a population, and most people divided it into pediatrics and adults. We need to bring forth a more nuanced conversation and understanding that there are subsections of people within each that have unique needs, and Rembrandt doesn't fit those needs. We need to understand that it requires community. We can't own it all as a health system. We need to partner and listen and hear what scares other entities, long-term care facilities, other people, etc., and collaborate, put the focus on this conversation about living and caring for this population. We're in our pre-adolescence, we're walking at the coffee table, so now is the time to really define what's possible. So when we were running our accountable care organization in my last position, we were ubiquitous. We were accessible and integrated everywhere a patient could be, with the exception of Dairy Queen and Harry's Bar. And I was not able to get those visits reimbursed, which is disappointing. When we look at why it's important to be available, and offer the greatest clinical feat that I ever did, against the backdrop of not being a very bright guy, was a new consultation with a woman named Sarah, who had a widely metastatic, so a cancer that had spread well beyond her lungs, which was the origin of the cancer. And she was pretty debilitated as this disease was ravaging her body. And again, not to be mean or curt, I mean, she was dead. Her life expectancy was markedly limited. And she, when listening to her little voice, came to that conclusion on her own. And we talked about that. She said, I would like to try some chemotherapy to see if we can prolong my life somewhat, because what's most important to me is spending time with my family and my grandchildren. But absolutely. And so my involvement initially was to manage symptoms of pain and shortness of breath. A couple weeks in, after a round of chemotherapy, her functional status, so how she was able to just live her life, diminished significantly. And she said, I think this is my inflection point. I think this is where I need to stop this, because I feel it's going to hurt me more than potentially help me. And I know we're not going to cure this. And a day or two after that conversation, she called me at 2 a.m. And she said, Dr. Tim, this is Sarah. And I said, Sarah, are you okay? Are you having any pain? She said, no. You have any shortness of breath? She said, no. I said, is Frank there? And I hear there's a gentleman snoring right beside her. And so obviously, he was asleep right next to her. She said, Doc, I just need someone on the phone. I need someone in this space. And subtextually at 2 a.m, this is when the closet monster is the fiercest. This is when that chasm of clinical reality to emotional reality, standing on that particular horizon, the abyss is so deep and dark and long. She said, I just need someone here, about acknowledging the human experience and her existence. And we chatted, and after a few minutes, she said, will you do me a favor? And I said, sure, what is it? And she said, will you read me a story? And I chuckled. I said, well, you got your choice of Curious George or Dr. Seuss. They've got little kids. And she started talking about when her kids were little, and then her grandkids, and we never got to the story. But we brought her full circle. We brought each other full circle, standing on that horizon with the inevitability of life. And after about 20 minutes, she was chuckling and crying, and we were both doing that. And she said, I think I'm going to be able to go to sleep now. And I said, okay, me too. And she died about a week or two later. And I would offer that was the most transformative clinical experience as a physician I've ever had. And it had absolutely nothing to do with medicine. It was having the courage to come to that space and stand right beside and make a difference. So how do we do that? How do we stand side by side? If we reflect on how great change and liberation has occurred throughout history, I can't help but think of this gentleman, Gandhi, and that in the last century, he was asked by colonial England if it was his belief that they would just peacefully exit India, for which they ruled over. And he said yes. And I often thought, how did he know? And it is very, very simple. He stood side by side, hundreds of millions of country persons, advocating for a positive, advocating for self-rule, autonomy. He did not go toe-to-toe with England, not antagonistic. He was for something, not against something. Throughout my career, I've learned that if I stand beside a patient and I advocate for what is sacred to them, have the courage to share with them the absolute reality of what's going on, good, bad, or indifferent, that it's going to be a success. It doesn't mean that we beat cancer. It means that we're able to live their lives and we can care for them predicated on their values. Early in my career, I had a woman I was caring for at home who had recurrent breast cancer that had metastasized to her brain. She was in her late 70s, and she said, "Doc, I want to stay here. I want to be comfortable. I get it. I'm going to die. I don't want any of those shenanigans." Okay, we'll do what we can. Her son came to visit and stay with her. He had an acute event, meaning one night, and it happened to be a Sunday evening, she started having severe chest pain and shortness of breath. She couldn't breathe. And her son called 911. Why? He was scared. Did he do anything wrong? Absolutely not. They take her to the emergency room. The emergency room physician says, "What's the problem? I'm having chest pain. I can't breathe." So instead of looking at her chart and seeing on the first page he had a recurrent, widely metastatic cancer, he called cardiology. Cardiologist comes in. Quick evaluation, chest pain, shortness of breath. Some of her enzymes are elevated, which may be consistent with something going on with the heart, maybe not. And again, he failed to look at widely metastatic recurrent cancer. And he walked in and he said, "Do you want to die?" I've never known anyone around the globe to say, "Yeah, pick me, that's fine." He said, "No." He said, "Then I have to take you to the catheterization lab." I came in Monday morning a little before 6. It was on my list of patients, and she was in the intensive care unit, and so I went down there. She was on the verge of respiratory failure, meaning a fork in the road of keeping you comfortable and you will die because your lungs will cease to work, or keeping you comfortable and then put a big tube down your throat and hook you up to a machine and you will die because your body is actively dying of widely metastatic cancer. I contacted the cardiologist, explained who I was and what was going on, and I heard the phone click. And I called him back. Started to explain again, and I heard another click. 2 minutes later, the individual presented in the intensive care unit we went to a side room, and I explained that she was able to express she did not want to be intubated. She wanted to go home and be comfortable. The same things she had expressed to me many, many times when I had visited her in her house. His response was, I asked her if she wanted to die, and she said no. I said, well, I think it's the wrong question, because she is actively dying, and you should ask her how she wants to live in this setting. His next comment was, she has rescinded, she has negated her do not resuscitate, so we could do the catheterization. I said, well, she can rescind it again because she doesn't want to be resuscitated. He said, I am not going to allow that because it will go against my 30-day mortality. And I looked at him, and the first impulse was to meet him on the playground after school. I said, this is not about you or me. At which point he said, I hope not, because all you do is euthanize people. I took a deep breath and I said, it's really about her life, her journey, her legal right to make a decision. In a tempest, he left the ICU. We got her home, and she died the next day, surrounded by family. Comfortable. If I had gone toe-to-toe, the outcome might have been very different. And while I wanted to go toe-to-toe, our role is to support each other as human beings, to stand side by side, espousing the truth, listening and hearing, and taking one step at a time together. And that's what this bigger conversation is about. Going from Rembrandt to Paula, slaying our dragons, living our lives. Months before my mom died, she was able to articulate, as she had so many times in her life, she wanted to be at home, surrounded by friends and family, and good Scotch from Ireland. And the reverent Irish woman she was, she said, this needs to be a celebration, not a mourning. And so I would encourage us and challenge us to think about Jackson Pollock, to think about embracing the unknown, walking to our horizons, seeking the truths that we can come back and share with others. That's how we change the culture, that's how we change the system, and that's how we live. That's what I wanted to share with you tonight. And I would love if there are questions, comments, concerns, philosophical observations. This is a uniquely human experience, and I would encourage us all to embrace it.